Well, I was a graduate from St. John's Medical College, and in 1971, I was doing my internship. I had been a good student and very interested in clinical work. And then a group of us went to Bangladesh, East Pakistan refugee camps, just to volunteer for 3 months of rural service. This whole experience completely changed my life. As a young doctor working in the community, I discovered that there was so much to working with communities, working with people, their lives, their social, economic, political, and cultural systems and values, which we are not at all taught about when we are in a medical college. And we always are focusing on disease rather than well being and health and on people's lives and their living happily and sort of contentedly and in a healthy way. And in those 3 months, I learned so many interesting, I had so many interesting experiences. And I think that really changed me from any sort of further continuation with a hospital oriented doctor drug model to trying to sort of work in my career towards how to build health outside of a medical college. And to some extent, when I came back and joined public health and then came back as a teacher in St. John's Medical College for about a decade, this was part of the quest. But it was very obvious that somewhere down the line, I would then move out, and that is how CHC began. The Indian Council of Medical Research in 1976 invited 14 projects community of the community health movement to a workshop, because by then there were serious reservations and serious concerns about the inadequacy of the rural primary healthcare model, which India had tried out and expanded since independence. And these 14 projects seem to have elements of a new way of thinking, and that is why this conference was called Alternative Approaches to Healthcare. Later in 1980, again, the same 14 were invited again, and another about 14 to 16 projects, about 30 projects. And from this, what emerged was that the alternative approach to healthcare included certain new elements which was to be added to primary healthcare thinking in the country. Remember, this was all in a way before and soon after Alma Ata. So, in a way, it preceded the whole Alma Ata declaration. And the focus was on things like health being integrated with development, the use of community health workers and local health resources, the whole issue of appropriate technology, and various other factors that we have put together in some of our articles, trying to identify. There were also issues like health cooperatives, sustaining community participation, introducing nutrition and health, involving women, and so on. And these were some of the new directions for primary healthcare in India. During the work in St. John's as a young faculty, along with a whole lot of colleagues, we evolved over a period of time about 5 to 6 community health projects. The most famous of them was Mallur Health Cooperative, which became one of the 14 projects that ICMR used as it tried to evolve its approach to alternative healthcare. When we came back after the ICMR meetings and after we discussed these new issues, we continued to develop these projects in St. John's. But what was important was to create opportunities for medical students and nurses to begin to think about these things, to see these approaches in healthcare. And it was clear that this would not be taught in a hospital, because we don't look at it from that point of view. And that's how the idea of rural orientation programs, community orientation programs, a much more planned rural internship and other things started. And this is what led us to more and more work in the community, moving beyond the teaching hospital and the medical college to the community. Later, when the ICMR, ICSR report came, the three a sort of three-part prescription which they gave at the end of the report fitted in so well with what we were already beginning to think was the way forward, that it really stimulated some of us to seriously consider leaving the medical college campus and starting a center that was dedicated to these new directions. Often people have wondered how does one differentiate this whole issue of biomedical model from the social and community model. And I think a good example is like if a patient came to you with cough, most of us would be worried about giving him a cough syrup or giving him an antibiotic and treating only just the cough or the infection that may have preceded the cough. But if we spent enough time with the patient or visited him in his family or in his community, we might suddenly discover that this cough has a much deeper link with either poverty or an unhygienic sort of home situation or a work situation that is very dusty or various reasons, or maybe a fact that he's had it for a long time but he may not have come forward for treatment because he comes from one of the socially excluded castes and so on. And therefore cough would then have a much deeper diagnosis where poverty, ignorance, bad work practices and so on would have to also be treated if we really wanted to help him get over his cough. The Community Health Cell, which later became the Society for Community Health Awareness, Research and Action, is a very interesting space that has been created by a very large number of us from multidisciplinary backgrounds who were interested in looking beyond the biomedical model. And what we have tried to do is build a new approach to health, which is deeply involved in a social and community model and contributes and emphasizes both responsibilities, which leads to community empowerment, and rights, which also leads to community action and a sort of social movement in health. We believe that health is very intersectoral and there are interconnected rights, and therefore various movements, whether it is for health, water, food, employment, right to information, are all linked, and that these must all therefore be a very large growing movement of people. The focus of SOCHARA initially was mostly on civil society and on NGOs and social movements, but over a period of time, we began to feel that this group must become a countervailing power, and we began to engage with government policies, with academia and research organizations, so that this new thinking in community would begin to mainstream. And this, I think, to some extent, has been the contribution of CHC. At some point of time, we also felt that a new generation of young health professionals, very early in their professional careers, must be exposed to these broader ideas and social determinants and the issues of rights and equity and quality, integrity and gender. And therefore, we evolved a community health learning program since 2003 at the 20th year of SOCHARA's growth. And since then, we have both promoting community health, learning about community health, and also training a new generation of health activists deeply committed to this new way of thinking. Community health is a process of enabling people to exercise collectively their responsibility to health and to also demand health as a right if that sort of facility or that sort of services are not available to them. From the very beginning, SOCHARA has always balanced rights with responsibilities, and therefore community empowerment has been as important and community-led action has been as important as getting the community to fight for its rights. In addition, we believe that because the medical profession and the health professions often control knowledge that makes well-being and health possible, we have stressed autonomy at individual level, family level, community level, and have defined it always as making available in the simplest way or demystifying health to the community. So these form the main basis of community health. Though over the years we have evolved many more axioms that support these three basic principles. See, the idea of the paradigm shift came up because, as we have mentioned earlier in some of our interviews that the whole SOCHARA was a movement beyond the biomedical model. Now, the biomedical model, the model which focuses on doctors, drugs, hospitals, diseases, is very, very dominant, and everyone thinks of health in those sort of medical terms. And so we created, over the years as we evolved our work in Sochara, a new concept called a paradigm shift, helping Sochara staff initially, people who visit Sochara to be work with us as partners, and Sochara fellows currently, to understand the shift from a biomedical model to a social community model. And we simplified it by calling it paradigm shift. Basically, it means that we are shifting an understanding of medicine to health by shifting the focus from individuals to communities. When we see people, we don't see them as patients, but we see them as participants of a program. When we think of a particular health challenge, we don't focus on drugs and technology and vaccines, but we focus on education and social processes that will help us to tackle those. When we look at even the research aspects, we will look not just at the pathological or the biological factor of disease, but we look at social, cultural, political, economic, ecological factors. And so this shift from looking at any health problem, whether it's HIV/AIDS, whether it's malaria, whether it's women's health, from a more medical model, we are shifting the paradigm to a social and community model, which has some of those determinants and some of those features that I've just mentioned. Well, right through the Sochara's history from the very beginning, because of the new paradigms that we were talking about, we brought people together to sit and discuss and to learn from experience and to understand from their community experiences and the social reality around them. And so learning was a very important part of the whole Sochara experiment. We were also inspired due to some earlier experiences with programs such as Search and our involvement even as medical college teachers with the Indian Social Institute and other places, with the whole philosophy of Paulo Freire, which looked at education to be liberating rather than oppressing. And the whole idea was to look at it not as facts to be banked in people's heads, but to provide information and facts that people can begin to solve their own problems and understand their own local situations. So the whole Paulo Freire approach to education, which is work, learning, sharing, creative thinking, and so on, became the sort of philosophy in which all our learning programs began. Initially, it started off with with NGOs, with visitors who came to us exploring their own experiences. But slowly, this whole new philosophy began to permeate all that we did, and finally, it also became a very integral part of the community health learning program.